Welcome everyone to Live from Cleveland Clinic. I want to thank all the people that have supported us today, Rita, Steve, Tim, as we talk about a very exciting topic, which is chronic pancreatitis. And I can assure you that every general surgeon is going to see patients with chronic pancreatitis. And what you're going to find today is a multidisciplinary approach to this problem, because every patient in this disease is very much an individual. And so we'll highlight that with some of the cases that we have. And we have a great multidisciplinary team that will, along with you in over 65 countries, including myself. I'm not even in Cleveland, Ohio. I'm in Mexico today. We're going to talk about chronic pancreatitis. I want to thank our sponsors, Cook Medical, Janssen Biotech, Medtronic, and Olympus Corporation for supporting these very educational programs. So without further ado, let me introduce our panel today. Again, very multidisciplinary. We have Julie Ali, who's the nurse for our multidisciplinary pancreatitis team. Tom Zagustin, who's a surgeon. Syed Multaheen, who is a pancreatologist. Rob Naples, who's a general surgeon. Hassan Siddiqui, who's an interventional gastroenterologist. And Rob Simon, who's also a HPB surgeon. So let's kick it off. Please, everybody, add to the chat. Part of my job is to field questions from the chat. Syed, without further ado, take it away.
Thank you, Dr. Walsh, for the introduction. So thank you for this opportunity, Dr. Walsh. I'll make this quick. I'm going to talk about pain management, especially medical management of chronic pancreatitis. All right, so my objectives for the talk are to talk about the natural history of chronic pancreatitis very briefly, understanding the pain mechanisms in chronic pancreatitis, as well as talk a little bit about the management of pain in chronic pancreatitis, dwell into a little bit of what obstructive and non-obstructive pancreatitis looks like. This is a slide showing you the natural history of chronic pancreatitis. Usually first patients get an acute pancreatitis episode. They might get more episodes of acute pancreatitis depending upon etiology. Some patients go on and develop chronic pancreatitis. We have established chronic pancreatitis as well as end-stage chronic pancreatitis. Some of the problems with this is that we are good at recognizing established and end-stage disease, which we recognize by stricturing as well as calculi in the pancreas, as well as the general appearance of the pancreatic morphology. We are not as good as recognizing early chronic pancreatitis, which is kind of a work in progress. So the pain patterns in chronic pancreatitis tend to be variable. If you see on the left of the slide, you have different pain patterns which can be continuous as well as intermittent in chronic pancreatitis. Pain can be persistent with some fluctuations. You can have persistent pain with pain attacks. You can have pain attacks with intermittent, mild, low-level pain in between them. And you can have intermittent kind of pain, which is pain attacks with absolute no pain in between. So as you can see, there's a lot of variation in the type of pain patterns that we see in chronic pancreatitis. And if you see on the right, these pain patterns tend to be variable as well as interchangeable. So a patient who's followed over a period of years can change from one pain pattern to another pain pattern. So there's a lot of heterogeneity when it comes to the type of pain that patients with chronic pancreatitis get. So we are kind of stuck, next slide. We're kind of stuck with this heterogeneous kind of pain in chronic pancreatitis, and some of the management should actually focus on managing the acute insult. Say, for instance, patient is alcoholic, so the management kind of depends upon managing or getting the patient to stop alcohol as such, as well as looking into some of or dwelling into some of the other etiologies that can cause pain. It's not always pancreatic. We need to establish if the pain is pancreatic first. And if it is pancreatic, then we dwell into whether this is an obstructive pain, meaning pain caused by obstruction of some of the ducts that run through the pancreas. And the obstruction can be either by stricturing disease or calculus obstruction of the pancreatic duct. Or is it non-obstructive pain, wherein patients get pain because of a lot of other mechanisms, which we can talk about? So we are dwelling whether we are acting as an electrician or a plumber, or in fact getting into surgical aspects. So if you see this next slide. So if you see this next slide, does pain correlate with morphology? If you see on the left, there's a CAT scan of a patient who has multiple calculi throughout your pancreas, but has absolutely no pain. And if you see on the right side, there's a pain wherein you see no calculi, you see some morphological features, but maybe none. And then this patient can have persistent pain due to pancreatitis. Next slide. So one of the key concepts I want to introduce here is that pain in chronic pancreatitis does not correlate very well with radiographic or imaging findings, even in advanced chronic pancreatitis. So if you see that graph, you see calcifications, atrophy, different features that are markers of chronic pancreatitis, but the pain does not correlate with it. Any type of pain, there are many types of pains that you can get in chronic pancreatitis. None of them tends to correlate well with that. Next slide. The other concept is that we have always thought of intraductal pressure, meaning pressure in the pancreatic duct, kind of correlating with pain. It does correlate when the patient has structural problems with the pancreas, but oftentimes it does not. So if you see the graph, there's a lot of heterogeneity in terms of the pain patterns. Next slide. So the other concept when it comes to pain in chronic pancreatitis is this perineural inflammation around the nerves that run around the pancreas, as well as endoneural inflammation. And this leads to a term we refer to as neuroplasticity, when in patients get pain due to neuropathic changes around the pancreas. And this is especially pertinent in non-obstructive chronic pancreatitis. Next slide. You see this slide, you will observe that there is a lot of, in patients with chronic pancreatitis, as observed to normal people, there's a lot of neuroplasticity. The plasticity and density of nerves around the pancreas is increased. This leads to chronic persistent neuropathic pain in chronic pancreatitis. Next slide. So just a quick concept of central sensitization, which just means that there's an amplification of pain response in patients who get chronic pancreatitis because of neuroplasticity. This pain response is independent of the source of pain. It affects the brain centers involved in emotion, cognition, and affect, and reduces the ability of the brain to control pain. Next slide. So when we know of central sensitization, there are certain predictors that can tell us that the patient is centrally sensitized. And we see this kind of a pain pattern in patients who are depressed, who are anxious, who are fatigued, they have poor sleep, and as well as autonomic dysfunction. So these demographic or kind of patients tend to have a heightened response to pain, and they fall into this category of patients who get neuropathic pain due to chronic pancreatitis. Next slide. I was talking about neuropathic pain, and then you get central sensitization. That's what we were discussing. Carrying forward, these type of patients are ideal candidates for neuromodulator therapy, wherein we give medications that tend to modulate a pain response. Pregabalin is a well-studied medication in this aspect. Of course, we use other medications as well, like gabapentin, but the maximum evidence out there is for pregabalin. We have recently also seen a lot of evidence for the use of antioxidants, and that tends to modulate or improve the response to some of these neuropathic medications that we tend to use. Next slide. So what is new in this whole field? We have something called quantitative sensory testing, wherein we use the convergence of somatic and visceral afferent nerves in the spinal cord, typically pancreas. We are talking about T10 dermatome, and we see what sort of hyperalgesia the patient has. Most patients have no hyperalgesia. These are the ones that would benefit from drainage procedures or endoscopic procedures. But a lot of patients have segmental hyperalgesia, wherein they have heightened pain response around the abdomen. And then there is a category of patients who have widespread hyperalgesia throughout the body, and they have central pain. And these patients typically would not benefit from drainage procedures. So how can we improve pain outcomes in chronic pancreatitis? Increasing awareness, incorporating best practices, of course. There's a multidisciplinary approach that's needed, and Julie's going to talk about it, I'm sure. And we want to develop new therapies to alter the natural history of chronic pancreatitis. So what did we learn? In chronic pancreatitis, pain has neuropathic as well as morphological components. It's something akin to wiring versus plumbing. We need biomarkers for hyperalgesia so that we can tailor therapy according to the type of pain patients have. Depression and anxiety tend to be major contributors and determinants of outcomes of pain response. And of course, a multidisciplinary approach is needed, which Julie will talk about. Thank you.
Thanks, Syed. Julie Ali is our nurse in our HPB clinic, and I can't stress how important her role is in patient navigation and patient facing, and she's going to give us her perspective on what it takes when we consider a total pancreatectomy with auto-islet transplantation. Julie, thanks for joining us.
Thank you. Again, my name is Julie, and I'm a nurse care coordinator in general surgery. And I'm going to talk to you today about the initial consultation for our total panc auto-islet transplant, the workup, and then also the follow-up care post-op. So again, we'll talk about the initial referral, and we talk about patients with chronic pancreatitis and those patients who are referred to us for a total pancreatectomy with auto-islet transplant. I'll talk to you again about the initial consults, pre-op appointments needed, and again, the post-op follow-up care. Next slide, please. In regards to the referral process with the pre-visit triaging, I do scope through our clinical patients for pancreatitis patients, or if I do have a referral from outside wanting to see surgery for the total pancreatectomy auto-islet transplant, I compile a list of our patients and I send out a meeting invite. We usually have 2 meetings. We meet twice a month at least. And we talk to the surgery team, gastroenterologists, and behavioral medicine. I'll send an email out to discuss patients' information about their pancreatitis and what type of pancreatitis that they have, whether it be acute, chronic, idiopathic, alcohol, pancreatitis, and give a brief synopsis. We'll go over the imaging that the patient has had completed, discuss any amylase, lipase lab work that is completed, any endoscopic procedures that they've had, we'll go over that as well. Genetic testing, what type of pain medication that they take, and if so, how much. And we'll also discuss as a group about these patients and collaborate and say, you know, we would recommend this patient to have additional consultations, either with pain management, smoking cessation, and kind of get a brief overview of a plan before we see the patient. In regards to scheduling for the surgery, the approach is that our patients will see general surgery, gastroenterology, behavioral medicine, endocrinology for a mixed meal test, and pain management for differential pain block. And that's typically our workup that we have for those patients. And we also, during this meeting as well, will review patients who are just starting the process and those who have completed the entire workup and where we are, and make sure everybody's on the same page to move forward with scheduling a surgical procedure. And again, if there are additional consults that are needed at that time, like imaging or chronic pain program, we can help get those patients consulted for an appointment when they come in and meet with us. You can go to the next slide, please. So on the patient's initial consult, they will meet with the surgeon, gastroenterology, and behavioral medicine. And we do an evaluation with these patients to explain the process of total pancreatectomy, auto-islet transplant, and set goals of the, you know, what the workup entails and what the surgery would entail, and outcomes after the surgery and how that will change, you know, their lives. If they wish to pursue moving forward with surgery, Then we will consult endocrinology, and I will reach out to one of our specific providers and get them scheduled for a mixed meal test. And that just includes about an 8-hour fast to evaluate glucose tolerance, insulin secretion, and evaluate their pancreatic function. And we'll get those results pretty quickly from endocrine. I'll also work to get them scheduled to meet with pain management, and they will be worked up for a differential pain block to determine if the pain is visceral or somatic, and then that will again determine if we're going to move forward with the surgery or another surgical intervention. Again, once these tests are all completed, I will keep track and I will bring it back to our pancreatitis meetings and back to the group, and we will talk about the results, and then we will also discuss if the next step is surgery or what the next steps would be for them. And this can take a couple of months. It is a lengthy process, but it's a huge lifestyle change that we want to make sure that the team is, the patients are ready for this procedure. You can go to the next slide. In regards to operative scheduling, so once the patient is approved to move forward with the surgery after everything is completed, I will work with our pharmaceutical team at Allegheny, and we will work with the surgeon's schedule to come up with a surgical date. It's about a 6 to 8 hour surgery, and it's a 2-part surgery, so we definitely want to make sure we carve out enough time on their surgery schedule to make sure that we can successfully do this surgery. And it is always a first start case because it's a lengthy surgery. I will update the patient on surgical dates that both Allegheny can do it and our surgery team can do the procedure. And we will work then to bring the patient in for preoperative appointments. They can choose to meet with the surgeon again. They will meet with me because I will have to give them splenectomy vaccinations prior to the surgery. And then we also have standard pre-op appointments, which include pre-anesthesia, EKG, chest x-ray, and a slew of blood work that we order for the patients. I will send an email to our administrators, surgery team, our OR staff, PACU and SICU teams, just to let them know when the surgery will be, and making sure that all teams are prepared and ready to accept the patient during the surgery. I will also send an email to, again, our pharmaceutical team once the labs are all completed. They typically want to know like height, weight, diagnoses, serology testing from blood work that has been completed, and then any allergies that they may have in regards to antibiotics that they would give for the islet production. You can go to the next slide. In regards to postoperative follow-up, the patient's in the hospital for roughly minimum a week, about maybe a week to 14 days or so. And then they'll be discharged and follow up with the surgery team about 2 weeks afterwards. A lot of times they will also follow up very closely with our endocrinologist if their blood sugars need assistance with management. I do have a list of our patients who have had completed auto islet transplant, and it's shareable for our group, our multidisciplinary team, to be able to access and review who's had this procedure or not. We are currently close to about 100 patients. I have 2 patients next month that will be coming in for this procedure, so that will hit us at the 100 mark of how many patients that we've had complete this surgery while here at the Cleveland Clinic. So that's fantastic. And people can access this for research and further assistance that they do need. So, and you can go to the next slide, or if there's any questions, I'm happy to help answer.
Thanks, Julie. Great job.
Thank you.
Again, highlight your participation in the group. You did allude to the fact that we want to make it clear to people that we do off-site, that means non-Cleveland Clinic islet isolation. This has worked out very well. It's actually now a private company that developed out of the research group at Allegheny that we partner with very effectively. We take the patients, since this is based on a question from the chat, they want to know how do we infuse the islets. We take the patients back because we anticoagulate them. We put them into the portal system, either via the splenic vein or a mesenteric vein, so that we can both measure the pressure effectively and make sure there's no bleeding with the pressure or the anticoagulation. And it's an open operation at this point.
Thank you so much, Matt, for the opportunity to present. Thank you for all the audience from the world over who is joining our call. I'm going to share my screen. Great. So I'll be talking about surgery versus endoscopy for painful chronic pancreatitis. My name is Thomas Augustine. I'm one of the HPB surgeons at the Cleveland Clinic. So what constitutes a symptomatic chronic pancreatitis? Patients with chronic pancreatitis, and this is pretty established literature, about 80 to 90% of the patients that have had chronic pancreatitis will have some chronic pain related to the pancreatitis. And most of the time, this is felt to be related to some sort of a duct obstruction. Julie talked about many of the management modalities. Dr. Moideen talked about many of the management modalities, but risk factor modification is key. You want to take patients off of alcohol. That's one of the most common causes of chronic pancreatitis, and all the other risk factors, whether that be triglycerides or gallstone related issues, need to be managed properly. There are other treatments that have been published about cognitive behavioral therapy, mindfulness therapy, but at the end of the day, narcotic avoidance strategies are quite key. And again, Dr. Moideen talked about many of those strategies around how to avoid narcotics. But then once you get to that point where a patient is on to seeking either narcotics or acquiring narcotics, or their pain is becoming hard to manage, what else can we do? And thankfully, this is one of those spaces where the literature is informed by randomized controlled trials. And this is, again, one of those very few places that randomized controlled trials have been done by surgical departments. So the key considerations in patients that are at that space where medical therapies have been maximized, risk has been modified, you want to ask a few questions. Is there anything else that's left to do from a behavioral point? You saw some of the comprehensive plans that we have for patients who seek total pancreatectomy. That's obviously available to all patients with chronic pancreatitis and pain related to it, including psychology visit, nutrition visit, pain management visit. So have we maximized all of that? And then the next question to ask is, what are we actually seeking to improve? Is it pain and quality of life, or are there some endpoints related to pancreatic exocrine and endocrine function? Once you get to the point of actually thinking about an interventional solution for or interventional management for chronic pancreatitis, you have to go through a stepwise process to be very clear about one, the diagnosis of chronic pancreatitis. There are other insidious diseases that can present like this. Chronic pancreatitis can also be masking an underlying pancreatic cancer. So it's really important to be very clear about the diagnosis of chronic pancreatitis, establish whether the obstruction of the duct is either related to stones, is it a stenosis, or is it both? And then you also should try and maximize non-narcotic analgesics. And when these patients get to severe recurrent pancreatic pain, which is not well controlled by these non-narcotic analgesics, or they're getting to the point of requiring opiates, then you should be considering interventional options for management of these patients. And of the interventional options, obviously surgery is one of the key options. Endoscopy has evolved quite a bit, but traditionally surgery has been in two big groups. There is the resection group of operations that we can do, and then there is a decompression group of operations that we can do. For the surgeons on the call, this is quite basic, but the resections can include a Whipple, a distal pancreatectomy, or a total pancreatectomy. On the decompression side, purely decompressive operations include the lateral pancreaticojejunostomy or the duodenum preserving pancreatic head resection, the Fry procedure. On the endoscopic side, again, we'll be talking about this. There is many endoscopic options. The key point to note is that these are all very advanced endoscopic procedures. The interventional gastroenterologists who do these procedures should be pancreatologists, people who are specifically experienced in ERCPs and with pancreatic procedures. Again, I would not go through the details, but there is a lot of endoscopic options that are available at this point. As I said, the decision about how to choose your patients for what kind of treatment is very well informed at this point based on 3 large randomized controlled trials. I'll be sharing the results of 2 of these. This was a trial that was published in the New England Journal of Medicine in 2007. The study group is actually quite small. It's about 40 patients, but the results are quite compelling. So these surgeons from Amsterdam randomized patients to either endoscopy or to surgery. The surgery that they did was predominantly a lateral pancreaticojejunostomy. 1 patient underwent a Whipple operation, but most of the patients just underwent purely decompression surgeries. On the right side, you see the graph which shows how their pain scores changed for the long-term follow-up that they did. So you can see on the x-axis baseline to 24 months, on the y-axis is their pain score. The solid square box is the endoscopy pain, and the round circle is the pain after surgical treatments. And you can clearly see that the difference in surgery versus endoscopy is maintained to favor surgery throughout the course of the patient's follow-up. As a matter of fact, about 70 to 80% of patients got complete to partial pain relief after surgery compared to about 40% in the endoscopy group. There were other benefits noted for decreasing of pancreatic insufficiency, or at least decreasing the rate of pancreatic insufficiency and endocrine insufficiency. These did not come out to be significant, but surgical treatment had a favorable result compared to endoscopy in this randomized controlled trial. Interestingly, complication rates were also comparable. This is a really important second study. This was published more recently in JAMA. Again, predominantly the same question was asked, whether or not early surgery versus early endoscopy is better for patients who have pain related to chronic pancreatitis. In their surgical group, they had, now this is a slightly larger study, they had 80 patients. And in the surgical group, they did both a Fry procedure as well as the lateral pancreaticojejunostomy. On the right side, you see the graph, and again, this is quite easy to interpret. These are pain scores. On the x-axis is the follow-up time. You can see that over a very long period of follow-up, surgery consistently had, patients undergoing surgery had consistently a better pain response compared to patients who underwent endoscopy. But there is still a lot of challenges that are left. Now, this is again from the JAMA study. It shows that while we make significant improvements with surgery and surgery is better compared to endoscopy, there's still a significant portion of patients who continue to have either significant pain or pain that's not really improved after all treatment options, and that could be up to 30% of patients. So we still are looking for better options, even with the availability of surgery and endoscopy. It's important to know what are the contraindications to these management options. So patients who have an altered, so first is endoscopic treatment if you have an altered gastric anatomy. If you have had patients who require surgery for some other pancreatic complication, or if you have had patients with previous pancreatic surgery, these are patients who would typically not be not go into the endoscopy treatment arm. And in the surgical group, of course, if the patient has severe portal hypertension or if the life expectancy is expected to be short, you would not consider those patients for surgery. So the final thoughts, while endoscopy and surgery are both options in patients who have pain related to chronic pancreatitis, surgery should be preferentially utilized when it is appropriate. Endoscopy can be used when surgery is not appropriate. Endoscopy can still be used as a bridge. However, the studies would suggest that as a first option, surgery should be utilized in patients who clearly meet criteria. It's really critical to have a multidisciplinary team before any interventions are performed. As a matter of fact, for most patients who undergo any treatment at the clinic, we would put them through our HPB conferences, and it's not just patients who require a total pancreatectomy. Almost all patients who have interventional needs for chronic pancreatitis would be presented. And I would say if there was one worthy goal, that was to avoid narcotics. Is a great goal in treating patients with chronic pancreatitis. Thank you so much for the opportunity, Dr. Walsh.
Yeah, thank you very much, Tom. That last point is always interesting when you look at quality of life in chronic pancreatitis, in the sense that it's whether you ask people are still on narcotics or not. Their quality of life may improve, but their narcotics use may not change. So it all depends how you ask the question.
That's correct.
Great talk. Hassam, are you up next?
No, it's supposed to be Dr. Naples, but Dr. Naples is not in yet. Can we go with Dr. Simon, please?
All right, let's do Rob Simon.
Yeah, hi, thank you. I am Rob Simon. I can do Dr. Naples' talk because I don't know if he's going to be out in time, but we can start with mine at least.
Start with yours.
Sounds good. So, I'm talking about total pancreatectomies and auto islet transplantation and when to operate on these people and when and kind of how we decide who's a good candidate for it. So again, chronic pancreatitis, it's a terrible disease. It's a wide spectrum of a disease as well. I have nothing to disclose, but my outline is going to be talking a little bit about chronic pain, addiction control, preserved endocrine function, genetic causes, some contraindications, and then some special considerations. So in terms of chronic pain, this is the main reason why we operate on patients and offer total pancreatectomy with auto islet transplantation. We have a nice long conversation with them. We have, as part of our multidisciplinary team, we have a pain psychologist who meets with them and talks to them and tries to get to the root of their pain and how it affects their daily lives. And oftentimes it really truly affects their daily lives and if they can work, their relationships. And so, it's very life limiting for them. We always do a differential pain block. And the reason for this is because we want to differentiate between centralized pain and visceral pain. And what I tell patients is that centralized pain is a lot like phantom limb pain in a way. And if they have a large component of their pain is centralized, then when we take the organ out, they're still going to have that centralized pain. They're still going to feel like the pancreas is there, just like patients who have an amputation sometimes feel like their limb is still present. And so the differential pain block is a surrogate for trying to give us the best data we can to try and determine who is a good candidate, who has a large component of their pain is visceral pain. And what they do is they inject a combination of local anesthetic and normal saline. They start with normal saline and they slowly increase the amounts of local anesthetic that is injected, and they ask the patient how their pain is during that injection. And if their pain goes down with the local anesthetic injection, then that's a good surrogate as to the component of visceral pain. And so that's a real big part of the workup of these patients to help determine who is going to be a good candidate for this. Because the last thing we want to do is take out somebody's entire pancreas, do a big operation on them, and they still have life-limiting pain. In addition, one of the big things that I've learned over the years of working with our pain psychologist is something called pain catastrophizing. And pain catastrophizing is something that can really contribute to centralized pain and can really contribute to somebody having persistent pain after surgery. And what pain catastrophizing is, it's a cognitive emotional response to pain. It involves three components: magnification, rumination, and helplessness. And there's a scale that people can use to try and determine what their pain catastrophizing is, but for the most part, it's a 3-point scale based off of how much they magnify their pain, how much they ruminate on it, and how much they feel helpless by it or helpless about it. So these are some of the tools that we use to try and determine who's going to be a good candidate based off of their chronic pain. In addition to pain, we want to make sure that their addiction is controlled. So smoking cessation and alcohol cessation. In particular, alcohol cessation. If a patient continues to drink without a pancreas, that can be life-threatening. The blood sugar control can be very difficult, and patients can die from it. And so the surrogate that we've started to use is something called a PEth. And what a PEth is I think of it like an albumin, but for alcohol. So PEth is a metabolite of alcohol, and it's fat soluble, and it sticks around in the bloodstream for about a month. And so if somebody's been drinking, it will show up, and it's a good way to kind of test and make sure that patients are truly abstaining from alcohol. And so we want to really make sure that patients have multiple PEths during their preoperative, workup and follow-ups to make sure that they have truly abstained from alcohol. In addition, we also, try and give them the support that they need to maintain that, and explain to them the severity of what could potentially happen if they start drinking again. Smoking cessation again, as well, it's not as much of a hard stop, to be honest with you, but it is something that we try and counsel them on, especially because after surgery they have fresh anastomoses, and the risk of getting marginal ulcers is not insignificant. And so we really try and counsel them and stress the importance of smoking cessation. Cotinine is a way to test to make sure that they've stopped smoking. We also want to make sure that before we do this operation and do the auto islet cells, we want to make sure that they have some preserved endocrine function. Otherwise, we would just do a total pancreatectomy and forego the auto islet transplantation component of it. And so one way we try and figure it out is we send them to our endocrinologists, who really are good at working with our chronic pancreatitis patients. They do a mixed meal test. So what they do is they feed them some carbohydrates, and they measure their C-peptide and their insulin levels, and they want to make sure that it increases, as well as their glucose levels, to make sure that they're able to maintain their blood sugars, make sure that they have an appropriate response in terms of their insulin and C-peptide, make sure that they're making enough insulin to make this component of this operation worthwhile. In addition, just kind of caveat, mild diabetes is not a contraindication. Oftentimes they can still have, a good amount of insulin production, and they can still have some decent results. So, overall, what we kind of quote patients based off of, the literature, particularly out of Minnesota, where this was all started back in the 70s, was that, there's a third of patients are medication independent at 1 year, meaning they don't need any insulin. A third are mildly diabetic, usually dietary modifications, maybe some oral anti-hyperglycemics, maybe a little bit of insulin, but it's pretty well controlled. And then there's a third that are brittle diabetics, and I'll talk about that in a little bit. But we like to, kind of try and counsel patients on what to anticipate. So the next thing I just want to mention is, genetic causes. So PRSS1, SPINK1, CFTR, these are some genetic causes of chronic pancreatitis. And in particular, PRSS1, SPINK1, CFTR, they can be risk factors for turning into cancer. And cancer is a big contraindication, which I will mention later, but a big contraindication for doing the auto islet cell transplant component of this. Now, when these patients, the average onset of malignancy is well into their 50s. And so if the patient is young, just because they have a genetic cause doesn't necessarily mean it's a complete contraindication for giving them the auto islet transplantation. If they don't have any signs of cancer at the time, they're having chronic recurrent acute pancreatitis, it's still okay to give them their islet cells back. So some contraindications, things that we really have a hard stop for if there's cancer, if there's any, if there's a real concern for cancer, we don't want to transplant those islet cells, basically giving them metastatic disease back into their liver. So if there's cancer, big contraindication. Again, those that are actively drinking, big contraindication. Autoimmune pancreatitis, the only reason I bring this up is because if they have autoimmune pancreatitis, usually there's other options that we try first before moving forward with the total pancreatectomy. And then in patients, as was mentioned earlier, patients with dilated pancreatic ducts, if they have a stricture, like a dominant stricture, or they have a dominant stone, we like to address those things first, either with a drainage procedure or with other endoscopic options to try and fix those causes of the chronic pancreatitis and the pain before moving to a total pancreatectomy with auto islet transplantation. And then lastly, some special considerations. So things to always remember, these patients after a total pancreatectomy, even with the auto islet transplantation, have severe exocrine insufficiency. And so making sure that they, are set up with a nutritionist, make sure that we counsel them on the correct way to take Creon, emphasizing that it has a very short half-life and that it's really important to take it with food so that it mixes with the food and helps you absorb those nutrients and the fats. And sometimes patients need 3, 4, 5 enzyme pills with meals. Type 3C diabetes, they can become brittle diabetics potentially, and it's different than your type 1 or even your type 2 diabetics because they don't have glucagon. So you have, the highs and the lows to battle. And so really getting them in with a good endocrinologist that is used to taking care of a lot of chronic pancreatitis patients is really important. And then making sure that they have a really good social support. And again, this is part of why we have them see a psychologist ahead of time to make sure that they have that good social support, because it's a big operation and it's a big lifestyle modification post-operatively. And it's really important to have long-term success. So just some key takeaways. Really, it's a multidisciplinary approach. It's imperative to taking care of these patients and really determining who's a good candidate and who's not. We work with our GI colleagues, our psychologists, our endocrinologists, our nutritionists, and we put our heads together to figure out who is the best candidate for this operation. Thank you very much.
Thanks, Rob. Let me remind the audience, please send us some questions in the chat. Rob, you mentioned not doing auto islets on people with cancer. What about precancerous conditions like IPMN? Are any of those patients candidates?
Yeah, I think that there are some that can be candidates. I think the big thing is just making sure that they don't have, significant worrisome features. Really do some due diligence ahead of time to ensure that you're not going to be operating on somebody with a risk of cancer. But yeah, if somebody has a low risk lesion, I think that it's completely reasonable to give them their islet cells back.
Obviously, you lose that opportunity for pathology, but
Mhm.
so that's why you have to consider it seriously. Syed, are you still on?
I'm here.
Great. Rob mentioned smoking cessation. How much does smoking tobacco, carbon monoxide from tobacco cause pain? How much should we try and get patients to stop smoking?
That's a great question. I think it's very imperative. We know from longitudinal data that smoking by itself is an independent risk factor for chronic pancreatitis. We used to think only of alcohol, but lately we are starting to think of more in terms of smoking as well, especially those people with small duct disease, meaning don't have an obstructive pathology going on, but still continue to have pain and they qualify as having chronic pancreatitis. I think it's imperative we get them to stop smoking.
Okay, thank you. Hassan, you're next. We'll wait and see if Rob shows up, Rob Naples,
That's
before
fair.
we cue you up, Rob Simon.
Sounds good.
Hassan, you're our interventional endoscopist. What do you have to share with everybody tonight?
So this is a real life patient I saw in my clinic. This patient is 29 years old. She has a history of epigastric abdominal pain, 6 out of 10. Sometimes it can go up to 8 out of 10 for last 2 years. This pain is progressively worsening, but over the last 6 months, she started developing additional symptoms of losing weight and having diarrhea. For a long time, she was treated with symptomatic management because 2 different gastroenterologists thought she had IBS, functional motility disorder. She was tried on antispasmodics and tricyclic antidepressants with no response. Then she was also tried on low FODMAP diet without success. She's very smart. She's working on her PhD thesis on prostate cancer chemotherapies. She was ready to defend her thesis, but because of worsening symptoms, now she's having problems concentrating on her studies. Next slide. She does not have any family history of cancer. She does not use alcohol or smoking. Her PET level is negative. She has no known past medical diagnosis. In her teenage years, she briefly used Accutane without any issues. Next. So outside facility where she resides had an ultrasound done because someone thought she had gallbladder issues, which showed an enlarged pancreatic duct, but normal gallbladder, which led to further imaging. Next slide. So at this point, what lab work would you check? You could check an IgG4 to make sure this pancreatic duct dilation is not related to IgG4 disease. We talked about PET levels. You could check a lipid panel. Other rare causes of pancreatic duct and pancreatitis issues could be HIV. You can check her liver enzymes again to make sure this is not a stone disease, calcium and hemoglobin A1C. Next slide. My question is, would you test a fecal elastase at this point, knowing that she had epigastric pain, weight loss, diarrhea, and on ultrasound, there seems to be an issue with her pancreatic duct? So maybe someone can put this in the chat, but I would lead this question to one of our panelists. Dr. Augustin, would you check a fecal elastase at this time to diagnose her condition?
Yeah, I think it would be critical to check a fecal elastase to see if her diarrhea and epigastric pain are related to chronic pancreatic insufficiency versus ductal obstruction that's causing the pain. Now, I didn't actually see the images, but you said the duct was quite dilated. Did you also see an obstructing lesion in the duct?
All right, that's coming up soon. So this has changed in the last 5 years. We used to check fecal elastase for the diagnosis of chronic pancreatitis commonly, if that's what she has. But in the recent 2020 American Journal of Gastroenterology, which is our ACG guidelines, have recommended that even though pancreatic function testing is important for diagnosing exocrine pancreatic insufficiency, its role is limited in the diagnosis of chronic pancreatitis itself. Next slide. Would any of you order genetics consultation? Rob, you talked a little bit about it. Would you order genetics at this time? I think, Rob, you're mute.
Rob, you're muted.
Probably not at this time, but I think I also don't think it's wrong to get them involved early.
Okay, so you're right. Someone did mention genetics, but her next available appointment with a geneticist in her local area was 6 months from now. Next slide. Rob already mentioned some of these genes. I'm going to mention a few more. We think about this genetic polymorphism in 3 categories: either acinar cell dysfunction, which is PRSS or SPINK1, ductal cell dysfunction, which is CFTR, or disease-modifying genes like CASR or CTRC. Next slide. So locally, she gets an MRI and MRCP, which shows isolated pancreatic ductal dilation to the level of the pancreatic head. They think it might be due to an obstructing calculus, or it could be the main duct IPMN. They measure the main pancreatic duct up to 7 millimeters in the head with an abrupt cutoff, and then even in the body and tail is dilated. Next. So this is our MRI, MRCP pictures. The main duct seems to be dilated with an abrupt cutoff at the head. Next slide. And this is another imaging series from the same MRI. Here you see the pancreatic head. I'm going to scroll down and scroll up. You can see some meniscus sign there, which is indicative of a stone. And if you follow the duct into the neck and here in the body, the duct seems to be dilated all the way to the tail. There is some mild dilation and irregularity of the side branches, as well as of the entire main duct. The bile duct itself is normal in caliber, and there are no stones or sludge. Next slide. So locally, she gets an EUS at this point because there is this confusion whether this is main duct IPM or not. The major findings here is that there was no fish mouth papilla. Rob, would you think that whenever you order an EUS to rule out IPMN versus chronic pancreatitis, is that something that you look for? The endoscopist makes sure he takes a picture or she takes a picture of the major papilla?
Always, always. I think it's really important in these patients that you really want to, rule out main duct IPMN. That's definitely on the differential, and looking at that ampulla is always very important.
Yeah, so I agree. I would recommend to our panel as well as to our audience that the endoscopist should always take a nice, clear picture of the major papilla, because sometimes that one picture is more important than any other information from EUS. But for this patient, there was no fish mouth. Her main pancreatic duct is 8.3, and there is an intraductal stone, which is causing an upstream dilation. The overall impression is chronic pancreatitis. At this point, would you like to see a surgeon or an endoscopist, or how would you approach it now? Maybe Julie, because you are sometimes the first person that the patient contacts. How would you go about it now?
I would just collaborate with both my surgeon and with GI, and I'm very pushy to help get the patients in if they need to see, surgeon right away and get them in within like a week to 2, to make sure that we can see them, or if they need to get an EUS or more endoscopy, we help arrange that if needed. But
so I think here the multidisciplinary care really plays a big role. So we have what we call an HPB conference every Tuesday morning. We are all in the same room. We have a radiologist. Julie helps us get all the imaging. In this case, it took a lot of effort to get all the imaging pulled into our system. But I think this is where being in the same place, same time, discussing together really helps. Next slide. So she saw a surgeon locally, and I copy pasted it not because I wasn't trying to type it out, but because I thought it becomes more meaningful if I just copy paste the actual letter that the patient had in her hand. They say she's aware that the option of endoscopic pancreatic stent placement and S-wall has been discussed with our team, but it is not recommended due to the poor results. They suggest phrase or pistols. So I would ask Dr. Walsh if you think, is that what she needs, a Frey procedure or a pistol?
So obviously the point here is that you have to combine endoscopic therapy with S-wall. Just trying to take out an 8 mm stone is not going to be successful with endoscopic treatment alone. A Fry procedure named after Charlie Fry or Charles B. Pusteaux procedures. There's certainly options. I actually haven't seen the CT scan. I've only seen the MRCP images. So if there's a huge pancreatic head and the stone, then actually a Fry is probably going to work better. But if it's not, then I think S-wall is an option. Even though we heard Tom's talk that surgery is going to do better.
Steve, next slide. So I agree, because her main symptom is pain. And as Dr. Augustine mentioned, there are 3 randomized controlled trials and 2 cohort studies. In long term, surgery has more durable results for pain control than endoscopy. Next slide. But real life is not randomized controlled trials. Real life patients have a whole social support system. For this patient specifically, she was planning to defend her thesis in 6 to 12 months, traveling to Cleveland and spending a lot of time in post-op recuperation was not an option to her because she would have missed her deadline for thesis submission. She said her school would be in jeopardy if she has prolonged absence, so she opted for endoscopic treatment. We discussed as a group, and everyone was on board that at least for the time being before she graduates, she should give an endoscopic treatment a go. Next slide. So her endoscopic treatment options would be here ERCP alone, ERCP with digital pancreatoscopy, ERCP with extracorporeal shockwave lithotripsy, or extracorporeal shockwave lithotripsy alone. Next slide. So ASGE have recently published their practice guidelines. This is American Society for Gastrointestinal Endoscopy. This is our international guideline makers. They recommend that in patients with painful chronic pancreatitis and main duct pancreatic duct stones, the optimal endoscopic approach is ERCP, ERCP with pancreatoscopy, or shockwave based on these 3 components. Number 1, for radioopaque stones more than 5 mm in the head and neck and the body, ASGE suggests ERCP with or without pancreatoscopy. For post shockwave lithotripsy and no spontaneous stone clearance after adequate fragmentation, ERCP should be performed. And for radioopaque stones less than 5 mm, and the patients have contraindications to S-wall, ERCP alone can be done. So our patient had an 8 mm stone, so she falls in the category of what we call aggressive endoscopic treatment, which is a combination of 2 different modalities. So in this patient, because she's young and fairly functional, I decided to combine extracorporeal shockwave lithotripsy with ERCP without pancreatoscopy, as per ASGE 2024 practice guidelines. Next.
Except, Hassam, you know, the question that they raise, that they're answering, ignores the fact that maybe they shouldn't be doing any endoscopy. They should just be referring to surgery. I'll just point that out. If you're choosing to do endoscopy, that's what you have to do.
Correct. So for painful chronic pancreatitis, if pain is the outcome, then surgery has longer lasting significant results. So this is extracorporeal shockwave lithotripsy. This is a Dornier 3 system. The pancreatic duct stone is visible on fluoroscopy. The four linear marks is how in 3D I'm targeting the shockwave lithotripsy on the stone. Patient is usually intubated, paralyzed. It takes about an hour, 20 minutes to do this. Next slide. There are no accepted standard of care for how to go about SWAL, but in our pancreatology circles, most people would use a Dornier Delta 3 system with 5,000 shocks. We can do about 90 shocks per minute at energy level 7. This has worked out for me well, but this is has been proven to be the standard in large scale studies. Next. I bring her back after 2 weeks of SWAL. I was able to cannulate her duct. The wire goes from her major papilla across the neck, crosses the spine. So I'm certain that the wire's in the pancreatic duct. You may have to play this video, Steve. Now I'm injecting contrast. There are some small fragments in the pancreatic duct. She also had a mild stricture in the neck, which I dilated with a 4 millimeter dilating balloon. Next. Because I left a 7 French stent, I brought her back. Next slide. This is repeat endoscopy. At this point, no further stones were seen in her main pancreatic duct. Her main pancreatic duct is now decompressed. Several balloon sweeps were done. And in the end, no stents were chosen to be left in. She also wanted to go home to defend her thesis, so I decided to leave her alone without a stent. Next slide. I spoke to her a couple of weeks ago. She's doing very well. Her abdominal pain is 1 out of 10. She has gained 5 pounds. She's about to graduate. She's on optimal dosage of pancreatic replacement enzymes, and she's not interested in surgery at this time. Next slide. One thing missing in her labs was that you may have to remember that one of the not so common causes or associations of chronic pancreatitis is celiac disease. So in fact, when she was checked for celiac in the very beginning, sorry, I held this information from you, both her transglutaminase IgA and her gliadin antibodies for IgA were moderate to severely positive. She saw one of our celiac disease specialists who was able to meet with her. Next slide. This prompted us to look into our data. This is one of our publications, the risk of chronic pancreatitis and association with celiac disease. And there's a significantly higher proportion of chronic pancreatitis that happens in patients with celiac disease as opposed to general population. Next slide. So I wanted to emphasize that multidisciplinary care is the way to go about this. ASG guidelines recommend the way to approach endoscopically this disease is based on the size of the stone and whether there is complete clearance that can be achieved or no. This can be done with ERCP, pancreatoscopy, or extracorporeal shockwave lithotripsy in any of those combinations. And don't forget to check for unusual causes of chronic pancreatitis, including celiac disease. Thank you.
Thank you, Sam. I want to go to a case that's in the chat, actually, that Fernando gave us. And it's a 22-year-old woman, so very young, has intermittent attacks of pain. It sounds like maybe one was from after an ERCP, but they now have a 14 millimeter duct and calcifications, gallbladders in, but no stones. Rob made some responses. I'll give my 2 cents as well. if you want to look in the chat for Rob's, I think intermittent pain is actually, by definition, the patient has chronic pancreatitis, they've got calcifications. So, and they've got a dilated duct. The issue is why. I think intermittent pain patients are actually very good patients because they don't have chronic pain yet. Is what I would assume by definition. And in a 22-year-old, I would definitely do genetic testing. That's the major point here because it'll make a huge difference as to what we offer. So for instance, if she has a clear genetic mutation like PRSS1, we're going to offer a total pancreatectomy and islets to take care of her pain. If we just manage the dilated duct and the stones, she'll keep getting recurrent pancreatitis, but every attack she'll lose some islets. So it's 7:12. Do we have time for my cool case, Rob, or do we save it for a future? We have time? Okay, Steve, I'm going to go through this fast. This is a good case that we just took care of. I'll go through it fast. Hopefully people will find it interesting. Next slide. So this woman was admitted for pancreatitis, also a patient with their gallbladder in. Is a drinker though, but now has sobriety. She's otherwise healthy, doesn't smoke. Next slide. When she came into the hospital, we talked about PEth scanning, PEth levels, which is very important. You can see that initially when she came in, she had a serum alcohol, so she was actively drinking. She had evidence of pancreatitis. And I have some imaging from 2004. So you'll see it's always good to have comparative images. And when she was admitted in March of 2024. Next slide. So here's from 2004. And you can see at that point, she has a totally normal pancreas. Next slide. Now she has some atrophy of her pancreas, and you can see she has maybe you can play it again, Steve. She has that very dense single calcification really right down by the ampulla. Next slide. So the question is, what do you do about that? Do we have a diagnosis? I think for sure we have a diagnosis of chronic pancreatitis, alcohol and etiology. So you're going to have to treat her alcoholism. But the question is, what should we do next? I don't have time to torture my colleagues on the panel. Next slide. So she had an ERCP, not done at our hospital. But what you can see is they're not able to remove the stone, but it's really at the distal part of the pancreatic duct. You see a wisp of the common bile duct, and that's normal. She has a stent in. So she has a small stent in. They were able to get past the stone, interestingly. Next slide. So what happens? So she's seen in polyps. She still has pain. She's on pain medication, now her PEth, so we can confirm that she's really, for at least a month, hasn't had alcohol. Let's see her CT scan now. Next slide. So you can see the stent in. You can still see the stone. So our presumption was the stone was the source of her pain, and she was requiring narcotics, and she had a failed endoscopic technique. So the question is what to do. And I'm going to show you an interesting option. We elected, so surgically, if we were going to approach this, most people would approach it through the pancreatic body. It's difficult to get that out when it's impacted right by the ampulla. Next slide. So we decided to do definitive treatment, which in this case was surgery for pain relief. And the goal is I have to remove the stone. I cannot just decompress the duct. That's the teaching point here. So the next slide. Here's the surgery itself. What we actually did, this is only 2 minutes, so it'll be short. We did a transduodenal sphincteroplasty. We went into the head of the pancreas following the stent, and we were able to extract the stone. So we opened the duodenum and the direction of the duodenum, not transversely. So we have more options if we need to extend that. Taking the stone out in the head. There you can see the pancreatic duct stent. Now we've also cannulated so you see the bile duct there is cannulated. I'm going to inject some epinephrine in saline. I'm going to follow that stent all the way down. It always is going to seem deeper than you would like. And ultrasound can give you some direction, but you got to follow the stent. That was the key in this case. And my hand is behind that so I can really push up the head. And now we're starting to see that stone right in the head. That's it. We're going to cannulate the pancreatic duct. And then remember, one of the reasons you want to have the bile duct is you want to do a sphincteroplasty of both the bile duct and the pancreatic duct. So we're going to basically oppose the mucosa of the pancreatic duct and the bile duct with the medial wall of the duodenum. You don't want to do this transversely because then you'll have a hole in the duodenum. The only hole you want is into the medial aspect of the pancreas. You can see how huge that sphincteroplasty is of that pancreatic duct. And then we're just going to close that duodenum.
That's so satisfying. It's a good case.
Yeah, it's really an unusual approach. Again, working with the endoscopist is great because that stent really is very helpful. Now we're just going to close the duodenum in the direction that we opened it. And the patient has had complete pain relief, no complications from the surgery. So we're expecting a durable result should she refrain from alcohol. Okay, are there any questions that the team has not covered? Well, I think hopefully the audience appreciates we have a great team. We're always available for questions by email. Just contact us. But hopefully it was fun. I learned things, and I hope we appreciate each other. Julie, you're holding down the fort. I know you're in my office. So thank you, everybody. Please look for the next Cleveland Clinic Live event. It's going to be on chronic GI disease, transitioning from pediatric patients to adult care. And we'll see you next time. That's going to be in March. Thanks, everybody. Thanks, team.